Alright, you guys, welcome back to the second lesson in our series of lessons covering the endocrine system. And in this lesson, we're going to be covering the differences between Addisons and Cushings. This is going to be the first dive into some of the disorders that we find within the endocrine system. But before we begin, if this is your first time to our channel and watching our videos, I do invite you guys to subscribe to our channel below. Make sure though you hit that bell notification icon, that way you will be notified as soon as our new lessons become available. As always, I truly value the subscriptions, the likes, and the comments that you guys leave for us, and so for that, I do want to thank you guys. My name is Eddie Watson, and this is ICU Advantage. Alright, so let's go ahead and begin with this lesson here. Like I said, we're going to be talking about the differences between Addison's disease and Cushing's syndrome. So both of these disease processes are very different from one another, but they're also very similar in the fact that they both are dealing with a problem with our corticosteroid production. And so to understand that, let's do a quick review of some of the anatomy that we talked about from the last lesson. So as we know, right here we have our hypothalamus. Here we have our pituitary gland. And down here we have our adrenal glands. And so what normally happens is we have the hypothalamus here that will release what we call corticotropin releasing hormone, or CRH. And CRH is going to go to our pituitary gland, and this is going to cause the pituitary gland to release what we call the adrenocorticotropic releasing hormone, or ACTH. And so for a quick check of understanding from the last lesson, in the comments below, let us know if you remember which part of the pituitary gland it is that's responsible for releasing ACTH. But so this release of ACTH by the pituitary gland is going to go down to our adrenal gland, and in particular the adrenal cortex, and that's going to stimulate the cortex to release several hormones. We have our cortisol, our aldosterone, as well as the androgens, or the sex hormones. And this is how this particular hormone pathway within the endocrine system is supposed to work. And so with that out of the way, let's go ahead and start to talk about the first of the disorders that we're going to talk about, and that is going to be Addison's disease. And so we know that we're going to have a problem with our corticosteroid production. And so in the case of Addison's disease, what we're dealing with is an acute adrenal insufficiency, and this can progress into what we call Addison's crisis. And so really what this means for us is that this is an acute form of a chronic adrenal dysfunction. And so what this means is we're going to have inadequate secretion of our glucocorticoids, which are going to be our cortisol, as well as an inadequate secretion of our mineralocorticoids, which is going to be our aldosterone. And these hormones are going to play an important part in what we see in Addison's disease. And so just think about this as inadequate or insufficient amount of these hormones. And so let's talk about some of the causes that are going to lead our patient into Addison's disease. And for these causes, we can really divide this up into three subcategories. The first one is our primary causes. And our primary causes are going to be the result of damage to our adrenal cortex. And so these are going to be things like our idiopathic autoimmune diseases, metastatic cancer, trauma, sepsis, AIDS, even drugs like phenytoin, barbiturates. So anything that destroys the adrenal cortex, that this is going to lead to an inability to produce these corticosteroids. So the next category we have is what we call secondary. And these are going to be anything that interferes with our hormone secretion. And really we're talking about interference with our ACTH secretion. So here things like pituitary tumors, radiation, hemorrhage, again trauma or surgery, or even any hypothalamic disorders, things that are going to lead to an inability of the pituitary gland to secrete ACTH and thus stimulating the adrenal cortex to release its corticosteroids. And finally, the last category that we have here is what we call the tertiary. And this is really going to be the result of long-term steroid use. And so what happens here is we have a failure of the adrenal gland to resume production of cortisol as a result. All right, so knowing that we have these different types of causes that are ultimately going to lead to a problem producing the corticosteroids from the adrenal cortex, let's talk a little bit about the pathology of what's happening in our patients who have Addison's disease. There's two major pathways that are really going to contribute to these problems that we see. The first is going to be as a result of our decrease in our cortisol level. And because cortisol is one of our stress response hormones, we're going to see things like decrease in our glucose production. We're also going to see a decrease in the metabolism of our fats and proteins, a decreased appetite, a decreased intestinal motility, a decreased vascular tone, as well as a decrease in our catecholamine effectiveness. And these are our epi and norepi. And so really you can think about this as our body having less of an ability to handle stress because we have less of this stress hormone that's available. And so when our patients become stressed due to many different sources, that this can often lead to profound cardiovascular collapse. And so this is our big concern with these patients, and oftentimes why you may be monitoring them within the ICU because they've perhaps experienced one of these stressing events and has ultimately landed them in the unit in your care. Now, in addition to the decreased cortisol levels, like we talked about, we're also going to have a decrease in our levels of our aldosterone. And we know aldosterone plays a very important role in our body's fluid regulation, and so this is going to lead to a loss of sodium, a loss of fluid, and as a byproduct, a retention of potassium. And so what this means for our patients is they're going to end up with a decreased blood volume, which if we add that on top of a stressing event, that once again they become high risk for this cardiovascular collapse. And so now let's talk some of the signs and symptoms that we're going to see with these patients. With Addison's, though, it's important to know that our signs and symptoms are often going to be nonspecific. So here we're talking about things like headache, fatigue, anorexia, depression, nausea, vomiting, fever, hair loss. You could also experience hyperpigmentation, hypotension, even shock in these patients. You're going to see decreased sodium, increased potassium, and a hypoglycemia that's really unresponsive to therapy. So none of these signs and symptoms are really going to jump out at us and tell us that this patient has Addison's disease. We're going to really need to look into these symptoms as well as some specific tests that we can perform to really figure out how to diagnose these patients. So first and foremost, we're going to need to take a look at our labs. So we want to check CBC, CMP, ABG, cortisol, and aldosterone levels. And really we're looking for that hypoglycemia, hyponatremia, hyperkalemia, and that decreased cortisol. And so based on these signs and symptoms and these lab values, we really may be suspecting that our patient has Addison's disease. And so if we do suspect this, then we're going to want to perform what we call the cosentropin stimulation test. And so what we do here is we give them a dose of this cosentropin, and 30 to 60 minutes later, we should see a rise in our cortisol level. And so if we don't see this rise, that this is going to be diagnostic for this adrenal insufficiency that the patient has. And so lastly, let's talk about the treatment. And our treatment for these patients are going to consist of primarily three things: steroids, fluids, and glucose. And so as you know here, our patients don't have enough steroids, so here we want to make sure that we're adding steroids in, and our glucocorticoid replacement is going to be our first line treatment. So these are things like our hydrocortisone. We need to get these levels up, which is really important for our patients to help prevent that cardiovascular collapse. Now, when we talk about our fluid volume replacement, we might be replacing as much as 5 liters in these patients in the first 12 to 24 hours. And so we're going to need to replace this volume, and we want to use either normal saline or normal saline with 5% dextrose. But early on in these patients, because of this volume loss as well as that possible cardiovascular collapse, you may need to use vasopressors as well until you can get this volume replaced. And finally, like I said, you want to replace the patient's glucose. And this is why you may choose to add that dextrose in with the normal saline fluid replacement. But it's going to be very important that we're providing glucose to our patients because right now they're just not going to be producing their own. Alright, so that pretty much concludes our talk on Addison's disease. Hopefully this makes this a little bit clearer for you guys. And just remember that Addison's is a problem with not having enough of the corticosteroids. And so this is why in our treatment we want to add those steroids back in. So if you're trying to really understand this, think about the problems that are going to come from having too low levels of cortisol and aldosterone. Alright, and so moving on, now we're going to talk about our Cushing syndrome. And so once again, we're going to have a problem with our corticosteroid production, but as you can probably figure out, whereas in Addison's we didn't have enough, in Cushing syndrome, we're actually going to end up with too much. And so you may also hear Cushing syndrome referred to as hypercorticism. And so like I said, this is where we're going to have an increased production of our glucocorticoids, mineral corticoids, as well as the androgen steroids. And so in this case, think we've got too much of the cortisol and too much of our aldosterone. And so once again, the increase in the amount of these hormones are what are going to lead to the problems that we see in Cushing syndrome. So once again, let's talk about some of the causes, in this case for Cushing syndrome. And there's really just a few causes for this. The first is going to be some sort of adrenal cortex tumor. So these are usually like our adenomas. And so in this case, a tumor in the adrenal cortex is going to be causing an increase in these corticosteroids. You also can see this in patients with pituitary tumors. And so what's happening here is the pituitary tumor is causing the pituitary gland to release too much of the ACTH, therefore overstimulating the adrenal cortex to overproduce these corticosteroids. You can sometimes see this in the case of long-term steroid use. And while this last case is pretty rare, it can be a result of some sort of ovarian or pulmonary neoplasms that are basically causing some sort of ectopic ACTH production. Basically, you end up with these tumors that themselves produce ACTH, thus overstimulating the adrenal cortex. So let's go ahead and move on and talk about the patho involved here, because it is going to be a bit different than what we see in Addison's disease. So once again, our normal process, hypothalamus releases CRH, tells the pituitary gland to release ACTH, which goes to the adrenal cortex, and thus produces its corticosteroids. Now, as we had talked about in the first lesson, we talked about that negative feedback mechanism, and in this case, the production of cortisol is actually going to cause the hypothalamus to decrease the production of CRH. And so this should lead thus to a decrease in production of ACTH and thus ultimately a decrease in our cortisol production. But we know in the case of Cushing syndrome, we have too much of this cortisol. And like we talked about in the case of these adenomas, that this is going to itself cause the higher release of cortisol independent of the normal process or pathway within the endocrine system. A tumor in the pituitary gland is not going to be impacted by the release of CRH or the lack thereof, and so we're going to continue to see that increase in the ACTH secretion, and thus ultimately the increase in cortisol levels. And as it's pretty obvious in the ectopic causes, we're going to see high levels of ACTH and thus high levels of cortisol as a result. And so one of the things that we're going to see as a result of this increased cortisol is this is going to stimulate our glucogenesis and our glycogenolysis. And so this means that we're going to have an increase in our serum glucose level as well as an increase in our glycogen stores in the liver. And you can think about these because these are normal processes that our body is going to go through in a normal stress response. And here we have too much of these stress hormones floating around. You're also going to see a decrease in protein synthesis as well as the catabolism of proteins. And then finally, there's a series of responses that we can really remember through the acronym BIG, which is BBIIG. So the first B is for elevated blood pressure. And so cortisol is going to activate the alpha-1 receptors, thus leading to a higher blood pressure. The next B is for inhibition of bone formation. Then the first I is going to be for our anti-inflammatory. The next I is going to be a reduction in our immune system response. And so finally, the G is for our gluconeogenesis, our lipolysis, and our protein lysis. And these again are all a response of that elevated cortisol level and thus that exaggerated stress response. And these are all going to come in and play an important role when we talk about the signs and symptoms that we're going to expect to see. In fact, a lot of them go along with some of these issues we see summed up within this big acronym. And so these are going to be things like hypertension, osteoporosis, our immune suppression. And so that's going to mean things like slow wound healing. You're going to see muscle weakness. And this is because of that protein lysis, and you're really going to often see this with thin extremities. And due to the increase in the storage of fat, you're going to see things like moon face, which is that big round face, the buffalo hump, which is fat storages on the back, as well as just a general truncal obesity. As a result of all this, you're typically going to see weight gain in these patients. You'll have that hyperglycemia, as well as the abdominal striae, or those red stretch marks on the abdomen, partially due to the increase in size, but also as a result of the impaired collagen production because of that protein lysis. Now, in these patients, because of the increased aldosterone production, you're now going to see hypernatremia and hypocalcemia, so the opposite of what you'd see in Addisons. You can also see excessive body hair, particularly in women, as well as these patients may be more prone to bruising. So there definitely are some very telltale signs and symptoms that you're potentially going to see in your patient here, especially with the round face and the buffalo hump. These can be dead giveaways that your patient has Cushing syndrome. All right, so with all that said, let's talk about how we diagnose these patients. So really our gold standard for this is going to be the 24-hour urine-free cortisol. But we can also do what we call the dexamethasone suppression test. And so if we give a dose of dexamethasone, we should see the body respond by suppressing the endogenous cortisol production. You could also look at imaging studies like an MRI, particularly of the head, chest, or abdomen. But once you've done these and you've diagnosed your patient with Cushing syndrome, there are other tests that we can do to help differentiate between, is this an adenoma, or is this a pituitary tumor, or some sort of ectopic ACTH production. And so if we check our serum cortisol as well as our serum ACTH levels, that this can help differentiate between, is this an adrenal or a pituitary or ectopic source. So if we have a low ACTH level, we know the hypothalamus and thus the pituitary glands are responding appropriately to the negative feedback and thus suppressing our ACTH production. Therefore, we know that those are fine, and so this must be an adrenal source. But in the cases where our ACTH is high, we know that this should be low because we have high cortisol. Therefore, we know that this is either a problem with the pituitary or some sort of ectopic ACTH production. And so if we do find the case where the patient has this high ACTH level, then we can actually do a high-dose dexamethasone test. And so by giving a very high dose of the dexamethasone, that if this is a problem originating with the pituitary gland, that with this high dose that we should be able to suppress the cortisol production. And so if we see the cortisol level is suppressed after this dose, we know that this is a pituitary problem. Whereas these ectopic sources of ACTH are not going to be affected or have any sort of negative feedback from this dexamethasone test, and therefore we're not going to see any suppression of the cortisol. And so finally, if we talk about the treatment for these patients, so it's really all going to revolve around controlling the cause. So if our cause is from long-term steroid use, then we're going to do things like slowly decreasing our steroid dose. If it's one of our other causes, we can look at things like surgery. And this could just be a surgery to remove the ectopic source of ACTH production. This could mean adrenalectomy, or you can also do a transsphenoidal surgery to take care of a pituitary tumor. But it's important to know that this may require lifelong hormone replacement therapy for these patients. And then finally, in the case of some of these pituitary tumors where surgery may not be an option, then we can look at things like radiation therapy, with the hope of shrinking and treating that pituitary tumor. All right, so that is going to finish things up in talking about Cushing syndrome. So as you can see, it's quite a bit different than Addison's disease. While they ultimately are both dealing with some sort of problem with the corticosteroid production, in the case of Addison's disease, we don't have enough of it, and so we're going to see different effects as a result of this decrease in cortisol and decrease in aldosterone, and typically you're going to see these thin, weak patients. Whereas in the case of Cushing syndrome, we actually have too much of the cortisol and aldosterone, and so we're going to see a different set of effects as a result of that. And this is oftentimes where you're going to see these large, potentially hairy patients, which really has this stand out when you compare these patients to the patients that you're going to see with Addison's disease. Two opposite ends of the spectrum when dealing with a disorder within the same part of the endocrine system. And so with that said, as always, I want to thank you so much for watching. If you enjoyed this video and you found it useful, please leave us a like down below, as well as if you'd be interested in more of this critical care education, then subscribe to our channel as well. In the next lesson in this series, we're going to go on to talk about hypoglycemia, as well as hyperglycemia and diabetes. So make sure and subscribe to be notified when that lesson becomes available. And in the meantime, feel free to check out the last series that we did, in which we did a good breakdown of heart failure. As always, thank you guys so much for watching, and you have a wonderful day.